Good. We'll go ahead and get started. Hi, Sean. Let's see. You can hear us?
Yep.
Yes, I can hear you.
Perfect. Hi, Nicole. Thanks. We'll go ahead and get started so that there's time for questions, as I know there's a good contingent on Zoom. So welcome to Grand Round. I'm Mari Momoto, one of the Grand Round committee members, and I am excited to introduce Huang, who is a former colleague of mine at Cambridge Health Alliance. Sean is a Fulbright scholar and assistant professor of psychiatry at Harvard Medical School, dedicated to improving mental health services on a global level. An expert in mental health services research, Dr. Huang has authored over 90 peer-reviewed papers to inform population mental health care. His commitment to large-scale service improvement is exemplified by his past role as a transforming clinical practice initiative master trainer on collaborative care, where he helped train more than 3,500 U.S. psychiatrists in this healthcare delivery model. Currently, he serves as director of the Consultation Liaison Psychiatry Fellowship and the Primary Care Behavioral Health Integration Program at Cambridge Health Alliance, while also creating educational content for the South India Psychiatry YouTube channel. We are excited to hear from you today. I'll let you take it away.
Yep. I have nothing to disclose. Hi, everyone. Should I get started? Sorry. Okay. Thank you so much. Let me share my screen.
And we can see it.
Okay. Is this okay?
Yeah. We're seeing your slide not in full screen.
Okay. Is this okay now?
Still showing
Okay.
like I mean, it's fine. It's just, it's not full screen.
Sorry, Mara. Is this okay?
Are you in slideshow mode for your
Uh,
slide?
I am.
Okay. I think we can all see fine. It for some reason is not in full screen slideshow, but again, I think like if we can't figure it out first.
Okay. Let's see here. Is that any better?
No, it's still the same.
Okay. That's okay. All right. Is this good enough like this?
I think so.
All right. I apologize. All right. Then let's get going. All right. So, all right. So I have, like I said, I have no conflicts of interest for this talk. And before I get started, I just want to really express my gratitude to two people who really set me on the path for working as a psychiatrist in primary care. So those people would be Wayne Caton and Jürgen Unitzer, with whom I trained some years ago. Okay. So the learning objectives today would be to describe bipolar illness, both the prevalence and the course of illness for this condition, to accurately diagnose bipolar disorder, and to differentiate it from something called unipolar disorder, which is an older term than present day major depressive disorder. And then also discuss some common treatments for bipolar disorder that really can be considered for primary care management. And lastly, to talk about some monitoring and implications for collaborative care for management of bipolar disorder. Okay. So the burden of bipolar disorder is actually pretty high. Um, you know, in general, we can say it's about 1% lifetime prevalence for both bipolar 1 and bipolar 2 disorder. If you kind of expand the definition to subthreshold bipolar disorder, the prevalence may creep up to about 3%. Mortality is higher in
Sean,
bipolar.
can we interrupt you just for a moment? This is us in the
Yes.
lecture. We are so sorry. Nick,
Yeah.
your slides were not advancing.
Yeah,
and so
no, they are.
They look good now.
Oh, so does this work like this?
That does, yeah.
It's working now, so that's great. You're still
Okay.
not in presenter mode, but I think we
Yeah.
can see you well enough.
Okay. Okay, let's try this. Okay. And so what we have here is higher mortality risk, which is actually really from cardiovascular events, as many here may know already. And it's about a 10-year decrease in lifespan compared to the general population. And you actually see a decrease in lifespan for most any mental disorders. And lastly, we have an increased risk for suicide. And this is even more so for bipolar 2 disorder than bipolar 1 disorder. And just to compare the differences between death from suicide and death from cardiovascular events, there are way more deaths from cardiovascular events than suicide, completed suicide. So before we get into how bipolar disorder presents, first I'd like to introduce a framework for diagnosing. And this is something that's really been proposed by a psychiatrist in the Boston area, Nasir Ghani. And in this framework, we would look at a hierarchy of diseases before coming to a conclusion as to what diagnosis we're landing on. And so at the very top of the hierarchy, we have manic depressive illness, or these days it's called affective disorders. And so you have bipolar disorder or unipolar depression. And what we see here is that when you have an affective disorder, you may have mood symptoms. Sometimes you'll present with psychotic symptoms, sometimes anxiety symptoms, and other times attentional deficit. And so this particular tier can explain many of the symptoms that a patient presents with. And then we would go on to psychotic disorders, such as schizophrenia, which is considered a primary psychotic disorder. And then moving down, you would look at anxiety conditions, in particular, obsessive compulsive disorder and panic disorder. These are very different than, let's say, generalized anxiety disorders. And then going down, increasingly we see more visits for patients requesting attention deficit disorder evaluations. So here's kind of a rule of thumb. Polysymptomatic conditions generally rank higher in your hierarchy. And also, even within each tier of the hierarchy, there are some conditions that would trump others. For instance, for affective illness at the very top, if you have a patient with bipolar disorder, they then in fact would not have unipolar depression or major depressive disorder. Okay. So here are some main features for unipolar depression, and it's really recurrent, severe depressive or low moods. Okay, marked by the absence of manic episodes, and so the patient may have a decreased interest or anhedonia, along with other psychomotor symptoms. And we'll get to why this can be difficult to diagnose, because depression as a symptom in itself is not diagnostic for a disease. So the treatment focus is generally monoamine agonists, that is to say antidepressants, depending on the depression type and severity. Psychotherapy and aerobic exercise is actually a really good way to improve depressive symptoms. For bipolar disorder, we're looking at recurrent episodes of both depressive symptoms and either manic or hypomanic symptoms. And the main difference between bipolar 1 disorder and bipolar 2 disorder is in bipolar 1 disorder, this is a bit easier to diagnose because the patient may present to the emergency department or subsequently in a psychiatric hospital for manic symptoms that could be marked by psychosis as well. In bipolar 2 disorder, it's actually quite easy to miss in all medical settings, including primary care. And so many times a patient who has been diagnosed with unipolar depression, in fact, may have bipolar 2 disorder because the hypomanic symptoms are very easy to miss. This is an instrument that can come in handy in your practice. Well, first of all, this is the screening question. If you have like zero time for anything else, have you ever had 3 or more days of decreased need for sleep? And then the example would be, let's say, sleeping only a few hours nightly, and felt irritable and did things that you would not normally do. For example, oversharing personal information, driving too fast, spending lots of money. And all of these are really dependent on whether the patient has a lot of money to spend or if they, in fact, are going to drive. So you just have to come up with examples that actually make sense for the patient. But this is, I would say this is better than no bipolar disorder screening, but I would actually advise to go a little bit further. And so my tip would be never assume a patient has major depressive disorder when in fact they may have a bipolar depression. So this is a little bit more structured and it could be helpful. It's called the CIDI or I call it the CD. I'm not sure if that's the correct term, but it is validated for diagnosing bipolar disorder in many different samples in many different countries. So let me just move back here. So the CD, you would ask a few questions. Like for example, there's an irritability stem and there's a euphoric stem. And if it's positive, you go on to one more question. And if that's positive, you ask a set of questions. So nine more questions. And depending on how many questions are endorsed, it gives you like a predictive value for the likelihood of a patient having bipolar disorder. So the main utility for the CD is it can be helpful to try to detect bipolar 2 disorder, right? And just a note, patients with bipolar 2 disorder, they actually spend a lot of time in the depressive phase, way more than the hypomanic phase, which may only be maybe 2 or 3% of the year, whereas they may spend up to like half the time in the depressive phase, let's say. One thing to consider is when we're trying to make a diagnosis and when we're trying to detect mood phases, for example, is a patient having hypomania or depression? A really common mood phase is, in fact, a mixed state, which is a combination of both mania or hypomania plus depression. Okay, in that sense, it can be a little bit confusing. So you have a patient who's irritable. Patients generally don't present with euphoria, but irritability and depressive symptoms. But a really good indicator for whether or not the patient has a mixed state could simply be motorcycle excitation or motorcycle agitation, right? It's like you can ask the patient, do you have this energy that you really can't manage or control? That could be also something to consider.
Hey, Sean.
Yes.
Is any way for you to enlarge your, either zoom in or enlarge your window so that the slides are bigger?
Is that better?
Much better. Thank you.
Thanks, Mari. I need this feedback. So you were just seeing like the classroom on the right side this whole time, right?
It's okay. This is better.
All right.
Yeah.
Okay. All right. Well, we can manage for sure. All right. So once again, this is the CD. You can download it easily from from the internet. Here are some differential diagnoses to consider, and I'll cover each common possible differential. In borderline personality disorder, the main trait is actually impulsivity, affective dysregulation. Although it's not one of the criteria for borderline personality disorder, there is good historical data that severe childhood trauma is oftentimes present in the history for patients presenting with this constellation of symptoms. So bipolar disorder presents with episodic mood phases or mood episodes, right? So you'll have sustained changes in the mood with bipolar disorder. In borderline personality disorder, sometimes you can say, "Oh, okay. Do you have to the patient when you have these mood changes? How long does it last?" And sometimes patients will say, "A few minutes, a few hours, maybe just that day," right? That's not a sustained change in mood. Additionally, oftentimes the patient may connect like a stressful life situation as a precipitator for the mood change. In post-traumatic stress disorder, you have the DSM flavor and you have a complex PTSD type. The main difference is in the DSM PTSD, you have usually like a severe incident that results in a constellation of symptoms, whereas in complex PTSD, that's really ongoing childhood trauma, and that results in a different set of symptoms. Regardless, once again, for bipolar disorder, you're really looking at mood episodes as compared to chronic, let's say, hypervigilance or chronic re-experiencing. And it's notable that post-traumatic stress disorder is actually not a disease, right? It's an injury. It's the one condition that's very different from all the other entities in DSM. In psychotic disorder, you'll really have sort of a history of, hallucinations, right? Psychosis. And in fact, in the old days, there was really only a continuum between neuroticism and psychosis, right? So this is kind of a very old and identified entity. But the symptoms are simply different. You have auditory or visual hallucinations, and mood symptoms can occur, but they're generally less common. And once again, you have to have episodic mood phases. For neurologic disease, there are many. It's numerous for the differential, and you really need to look for other symptoms that may indicate a neurologic process. So, multiple sclerosis, Huntington's disease, Wilson's disease. The list is quite long for this differential. For medication-induced causes of mania or hypomania, I think there are three to really keep in mind. One is the monoamine agonist class, right? So serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and most of the other ones in that category. So without any mood stabilizer as part of the treatment for the patient, there is a higher risk for inducing a manic episode. And this is a very common presentation in primary care, which is a patient may have been prescribed a antidepressant for, let's say, 5 years, maybe a decade, and never really found a benefit. Okay. So it's not diagnostic, but there is a chance that the patient may have had treatment failure, right, quote unquote treatment failure, because antidepressants simply do not work for bipolar depression. Okay. In fact, patients may be more likely to have, let's say, the irritability or hypomanic symptoms. The second medication to keep in mind are corticosteroids. You may see more in the hospital setting with sort of high dose steroids, but it's also possible to see it in the outpatient medical setting as well. So something to keep in mind, if you look at the medication list, you may be able to figure that out. And lastly, amphetamines. So like I mentioned in the very beginning of this talk, many patients do present with requests for evaluation of inattention symptoms. And so, one of the commonly recommended treatments is an amphetamine. And so you really want to be cautious with amphetamines, especially in a patient who may have a manic depressive illness or bipolar disorder. Okay. So how do we go about treating bipolar disorder? First, it's helpful to think about mood episodes in different phases. Okay. First, it would be, you can have an acute manic phase, right? Now, for a true acute manic phase, probably an inpatient setting would be ideal. Okay. An acute depressive phase, that may also bring the patient to the healthcare setting for help. But once the patient is psychiatrically optimized, ideally they reach euthymia. That's the maintenance phase. So for the management of bipolar disorder, you really would want to think about which phase are you treating. Probably the most common phase in primary care would be an acute hypomanic phase, but even more common would be an acute depressive phase of bipolar disorder. Okay, so if you can see from this table, my colleagues and I wrote up a clinical guide for the title of this talk, Assessment and Treatment of Bipolar Disorder in Primary Care. But we really relied on the CANMAT, which is one of the many sort of expert consensus guidelines for the treatment of bipolar disorder. So I'm not sure if this shows up, but there are little asterisks next to each of the drugs, and only a few of them satisfy the criteria for working across all phases, right? So that would be lithium, quetiapine, lorazepam. So these are things to kind of keep in mind. But in general, that the mainstay treatment are really mood stabilizers for bipolar disorder. Okay, so they generally work on second messenger systems, so kind of downstream of the receptor. But once a patient has reached stability, psychotherapy is important. Managing circadian rhythm is important. Reducing stress as well, and simply monitoring for early signs of a mood episode. Okay. All right. So I like to cover two medications for consideration for prescribing in primary care. For a very long time, I've diagnosed patients and managed patients with lamotrigine in the primary care setting. And so we'll cover this first. So the mechanism of action is generally understood to be sodium channel blocking. It has better efficacy for depressive episodes and not much efficacy, if at all, for acute manic episodes. So if a patient presents with in the acute manic phase, you'll need to consider other medications. So generally in the dopamine blocking class, antipsychotics or benzodiazepines. Okay, but here's the importance about thinking phases again. When something works in one phase, it doesn't mean that you'll want to continue it once a patient reaches another phase, right? So it's a very common scenario in which a patient would be discharged perhaps from a inpatient psychiatric setting on a regimen that may not be suitable or needed in the outpatient setting, right? So they probably don't need the benzodiazepine anymore if they're out of the acute manic phase or depressive phase. They may or may not need the dopamine blocker, but they certainly would benefit from some sort of mood stabilizer. So the lamotrigine advantages are it's fairly well tolerated. There's no laboratory monitoring needed. It has a lower potential for weight gain compared to some of the others in this class for the management of bipolar disorder. And it doesn't have any known malformation risks. So for a patient who may be planning pregnancy or is already pregnant, lamotrigine could be a reasonable option. Some common effects that accompany the beneficial effects include nausea, GI upset, a benign rash, some CNS effects as well, such as dizziness or headache. The serious adverse event is Stevens-Johnson syndrome. So the absolute risk is low, but if it happens, it's quite dangerous. And so one way to minimize this known risk, is to titrate slowly. And the reason is the risk for Stevens-Johnson is the highest at the very beginning of exposure to lamotrigine and at each dose increment going upwards, okay? So if you look at, let's say, UpToDate or any sort of prescribing manual for lamotrigine, at least for bipolar disorder, I'm not so sure about the titration for epilepsy. It usually goes something like 25 milligrams of lamotrigine daily for 2 weeks, 50 milligrams daily for 2 weeks, 100 milligrams daily for 1 week, and then up to 200 milligrams daily. Okay, that's the dosing for bipolar disorder is usually lower than for seizure disorder. So that's what you'll read. But if you know that at each dose increment, there's a higher risk for Stevens-Johnson syndrome, I would suggest actually to go up by 25 milligram increments at each time point. So instead of going from 50 to 100, which is 100% increase, go from 50 to 75 for a week or two, and then proceed on the titration if needed. Some patients may benefit from lower doses of lamotrigine, 50 milligrams daily, 100 milligrams daily, and then of course some patients may need 200 milligrams daily. Some major or some notable drug interactions include valproic acid or valproate and lamotrigine. So you may need to adjust the dosing in that way if both are co-prescribed. Estradiol-containing drugs can also reduce lamotrigine levels, so that's something to consider. Okay. Lithium. So like I mentioned, for several years, lamotrigine has been sort of the main treatment for me in the primary care setting, because I find that many PCPs can feel comfortable managing if needed in primary care. However, more recently, I would say probably in the last few years, I'm sort of promoting lithium as the standard treatment. And the reason is because it's really the best medication in psychiatry. Okay. So it's effective for both manic and depressive episodes. In acute mania, the doses may to be higher. It does have some neuroprotective properties, and there is this association with reduced dementia rates for those who have lithium exposure. In addition, it's the only medication or treatment in psychiatry that reduces suicide completion, right? So it significantly reduces suicide risk, as opposed to clozapine, which has some evidence in reducing suicide attempts, right? For suicide completion, we're not so sure about that. But there are some observational studies where low levels of lithium in the drinking water is also correlated with reduced suicide prevalence. So it works by altering neuronal sodium transport, among many other mechanisms. So here are some things to consider if you are thinking about using lithium as a treatment for your patient, or already prescribing lithium. Let's say you're in a part of Washington State where it's maybe difficult to source a psychiatrist for your patient. So when you start lithium, I recommend starting at a low dose, right? Anywhere from 150 to 300 milligrams daily, and then kind of go slowly from there. So what I have here on lithium levels, these are really the levels. So 0.6 to 0.8 is generally the maintenance level in the literature, whereas 0.8 to 1.2 is for acute mania, which generally you probably wouldn't see in primary care. You wouldn't be managing anyways in primary care. So the 0.6 to 0.8 come from the NICE guidelines, and I think it's something to keep track of if you get to a high enough dose. But generally, if you go from 300 and you're titrating by 150 each time, every week or two, you may not even need to check lithium levels at the lowest dose. Okay. And some patients do very well on low dose lithium. You'll want to check a baseline thyroid function, check a basic metabolic panel to see that the kidneys are working okay, because lithium is renally cleared and not metabolized by the liver. Pregnancy test is important because it is a known teratogen. It can increase risk for Epstein's anomaly. And then if there's a cardiac disease or family history of cardiac disease present, can be EKG to see that everything's okay before starting lithium. The most common effects, other than the therapeutic effects, are nausea, diarrhea, especially in the beginning of treatment. There could be a fine tremor that's dose-related. Polyuria, polydipsia is possible. Concentration problem can also be possible. Weight gain is a real common side effect as well. And then hypothyroidism can occur in 10 to 20% of patients. In this case, you would stop the lithium, and it does resolve. The most serious considerations include arrhythmias, nephrogenic diabetes insipidus, and also if a patient gets dehydrated, especially in hot weather, and they're not hydrating sufficiently, you can bump up the levels of lithium by concentrating it in the blood. So the one thing about lithium is that there is the concern about sort of kidney disease with long-term or chronic use of lithium, and that's about like 1 to 5% over 20 years at sort of therapeutic doses. And so for this reason, once daily dosing is recommended, as it kind of limits the number of sort of hits to the kidneys, and also working with the lowest working dose rather than trying to hit a therapeutic window based on lab tests. Okay. So all right, collaborative care model is something that was developed at the University of Washington, and sort of the main person to kind of explore and to grow this delivery model was Wayne Caton some years back, decades ago. And so initially it was developed for the management of depressive disorders in primary care settings. And, there would be a behavioral care manager that would perform a comprehensive mental health assessment, keep a registry to discuss cases with a consult psychiatrist once a week, to sort of use step care interventions to move the needle on certain measurement-based instruments such as the PHQ-9. Okay, and so it's a population health model, and it's caught on nationally, and it's being implemented in different healthcare systems in the U.S. and it's also studied in other countries as well. So more recently, this model of care has been considered in more complicated mental conditions, including bipolar disorder and post-traumatic stress disorder. So most of the authors on this particular study actually work at University of Washington. So they essentially compared the collaborative care model with sort of a referral to telepsychiatry model, like a usual care arm, and they seem to both work fine. So this is one of the very few studies that have looked at collaborative care for bipolar disorder. At this point, I'm not aware of another study to kind of look at this question, but I think it's just something to keep an eye on. Perhaps a system of care can build bipolar management onto existing collaborative care treatments for depression or unipolar depression. Okay, so there you go. I do have more educational content on my very modest YouTube channel that kind of covers some of the elements in this talk and other topics as well.
Thank you.
Sorry about my technical deficits.
Questions?
I'll ask a question. I'm Kim Collins. Sorry, I'm gonna pick which camera to look at here, but one of the attendings here in family medicine. And thank you for. I think it's helpful to kind of have a framework to think about, diagnosing bipolar disorder and meds. You mentioned using lithium and lamotrigine. Are there times where you might think about using an antipsychotic first line, like in the primary care setting? Are there times where we might think about using those? I know Seroquel is something, that a lot of us feel, somewhat comfortable with. So what would, those things?
Yeah, that's a great question. The main thing, the main concern that I have with atypical antipsychotics, which is, right, so we have generally typical antipsychotics like haloperidol, and then atypicals with anywhere from aripiprazole to quetiapine to clozapine. My main concern is the metabolic disruption from this class of medications, and that's kind of why I said in the talk, if you're treating the acute phase, okay, if that's and that may be simply what you need to manage, in that particular situation. So probably risperidone is kind of a little bit less metabolically dangerous. It does have some sedating properties. If you're not using it long term, you may not have to worry about the increased prolactin levels. But quetiapine or Seroquel is you could. I would just be very cautious with it and think about the different phases that you're treating. And if it happens that if you were to manage from acute to the maintenance phase, I would probably start a mood stabilizer in that acute phase concurrently, and then have the mood stabilization take place, and then taper the atypical antipsychotic. Yeah. So even though quetiapine is FDA approved, if you want to look 10, 20, 30 years down the line, the patient's placed at risk for different other events.
Great, thanks. I know that's helpful.
Other comments, thoughts?
I think some of my I'm one of the faculty. Some of my hesitation with lithium is the toxicity risk and the need for monitoring of levels. Are there, and then I guess my hesitation with lamotrigine is like the disruption, right? If they miss a few doses, having to worry about Stevens Johnson. Are there patients in which you think like this is a good candidate for lithium or lamotrigine, and this is maybe not a great candidate?
Yeah, I mean, I think if you're managing mostly the depressive symptoms, lamotrigine can still be on the table as an option. But if you do have sort of, it doesn't work well for manic episodes. So in that case, you can go back to thinking about the acute phase, right? If a patient has an acute phase, either manic or depressive episode, then you may bring in your atypical antipsychotic, treat the acute phase, maintain the lamotrigine. Yeah, that's one way to go about.
I guess I have a quick question. I'm Kevin, one of the residents. Hello. I know that sometimes antipsychotics are added onto treatment regimens for major depressive disorder if they're resistant to treatment with just SSRIs. Is it aripiprazole that's normally used as the adjunct therapy? I'm just curious when you turn to that and trying out something in combination versus saying, okay, well, maybe this isn't major depressive disorder. Maybe I need to try one of the other non-SSRI antidepressant meds that are starting to come out. I know it's not exactly related, but I feel.
Yeah, that's a common that's a super common presentation. And what I would say is first I would revisit the diagnosis if we in fact have an undiagnosed bipolar depression. So you use the CD to kind of help guide your questioning, to kind of reassess. Because what happens is a lot of times patients who are given the treatment-resistant depression diagnosis oftentimes have bipolar depression, right? So I would first reassess, and if it's unipolar depression, okay, so only depressive episodes. In that case, if you were to use aripiprazole, which does have that approval, usually 2 to 5 milligrams is as high as you would want to go. That's actually the optimal augmentation dose, right? So and you'll see that most of the atypicals have sort of this pan effect on different psychiatric symptoms. So the advantage is that among the atypicals, aripiprazole is less likely to induce weight gain. They can still cause some metabolic effects. It's a little bit more likely also to cause akathisia, so that's something you want to watch out for, especially for a younger adult. It's a very uncomfortable feeling in which there's no real sort of resolution to it, no matter what the patient tries to do.
Thank you.
Sure. Thanks, Kevin. Hi.
Yeah, hi. I have another question. Kim Collins again. I think sometimes in primary care clinic, we end up in a little bit of a diagnostic conundrum with is this maybe bipolar disorder? Is this maybe depression with some, just features of insomnia? Do you have treatment recommendations for when we're sort of not exactly sure which category someone falls in, because generally, the bipolar treatments maybe, I don't know how much they help necessarily in just unipolar depression. Any thoughts about that? Or that before we can get into the psychiatrist?
I think it's hard for me to comment. If I think I would still try to aim for sort of diagnostic clarity. At the very least, if you're working at the top of the tier in that hierarchy, at least you're working with an affective or mood disorder, right? So I don't think it's actually too practical in primary care, but lithium can be also effective for major depressive disorder. That would cover both poles actually. But yeah, I would really try to once again kind of reassess to try to clinch the diagnosis because that really does direct you to one set of treatments, which is exercise, right? Maybe depending on the type of depression, light therapy, psychotherapy, monoamine agonist versus a second messenger modifier like a mood stabilizer. So I think the treatments are so different that I would still try to reassess.
Sean, this is Joey. I'm the interim residency program director here in Seattle for Family Medicine program. I just wanted to appreciate and say thank you for leading this discussion. I think it's often kind of like, not widely known that primary care physicians, family medicine docs are able to do this type of work, to be able to stabilize folks who are experiencing mania, to be able to prescribe these medications. And I think it's also just great for our residents to be able to hear that, to feel empowered, and when they're going on their psychiatry rotations, to really lean into this opportunity. I also really appreciated your mentioning of, pregnancy care and breastfeeding care and all that kind of stuff, all those different unique elements that occur for us as family medicine docs. I'm just wondering, with that element in mind, is there any just advice you can give to us as family medicine physicians stepping into this world?
Yeah, I think you mean for management of sort of like common mental disorders? Is that right?
I would say more so like acute mania and things like that.
Yeah. Oh yeah, sure. Yeah, I mean, I think I try to cover more of sort of in this talk the hypomanic perhaps presentation or the acute or chronic depressive phase. But if in fact you have anywhere from hypomania to mania, you would want to kind of go with a combination of medications, which would include an atypical antipsychotic, possibly. This is one of the few times I recommend benzodiazepines, where I think there's actually a clinical indication. A benzodiazepine, and then use your primary care based protocols for transferring the patient right from primary care to the hospital.
John, I have one more question for you. Do patients typically present with bipolar 1 or 2 in certain age demographics? Does it normally come about in like the 20s and 30s, or can it be a delayed presentation in the 60s? I mean, I guess then it gets confounded a bit with like different dementia and neurologic.
Yeah, that's so what one thing that I actually didn't cover adequately is, well, first let me answer that question. Typically, the onset for either bipolar 1 or bipolar 2 disorder is before 25 years of age. And in fact, you see the onset, you see, kids presenting with symptoms that, the pediatrician or the family medicine physician is like wondering like what exactly, in kids, it's just much more complicated, right? The conditions are often undifferentiated up until you kind of have more data. And so many a times there's symptomatic treatment. But the thought is that the symptoms present before sort of later in the adult years. it is possible for patients to develop manic symptoms later after 40, but then you would kind of expand your differential to medical causes. But coming back, I wanted to kind of just touch a little bit on, how, apart from just the symptoms, how do we sort of think about psychiatric diagnosis in general? And you can apply this to any condition on that hierarchy framework. So, basically we have 4 lines of evidence, right? One is kind of characteristic, right? What are the symptoms? One is the course of illness. So exactly what you mentioned, like when do the symptoms start, right? And sort of what does resolution look like, right? So for example, in major depressive disorder, once you have an acute onset of a depressive episode, usually it resolves in 6 to 9 months, right? So somewhere in there, which is about the time that a patient is kind of, on a monoamine agonist. So the other one is genetics. So, this is where family history really comes in. And lastly, biomarkers, which we don't really have much in psychiatry. And in this case, the second best thing is really a proxy, which is treatment response. This is not the best because there are some drugs in which every person responds to, right? If you receive an amphetamine, everyone would have improved focus. If you receive benzodiazepine, whether or not you have a psychiatric illness, there would be an anxiolytic effect. So that's not the best proxy, but it's kind of the best we have right now. So you want to pull in all these lines of evidence, not just the symptoms that you see in the DSM, right? Because just think about how easy is it to meet criteria for major depressive disorder, right? It's too easy. 2 weeks of these very common symptoms gives you a disease, which leads to pharmaceutical intervention. So.
Thank you.
So I was just curious, and sometimes in primary care clinic, we see people who have reported a history of bipolar disorder, but are no longer on treatment. And usually, I often think of bipolar treatment as being lifelong. And I was just wondering if aside from clarifying the diagnosis, right, which is what sometimes has to happen, I was just curious if you could talk about duration of bipolar treatment, and is it generally considered lifelong? Is that related to, risk of mania? Just if you had any comments about that.
Yeah, if in that case, well, I think there are 2 ways to go about collecting the history. One is, okay, let me back up. So like the natural course is you would someone with bipolar disorder or manic depressive illness, the mood episodes are recurrent. They'll continue at some point. There'll be a relapse, right, of sorts. And many times patients are not well, even if that's like their baseline. And so, like I said, mixed episodes are quite common. What you'll probably, if there are like kind of very pronounced examples of symptoms that if something resulted in a psychiatric hospitalization, that's like a marker, right? Or if someone has lots of genetic loading, no matter what psychiatric disease, that could be also an indicator of sort of psychiatric severity. And what's very interesting is, there may very well be also a common pathway for all diseases, right? Which is mitochondrial dysfunction. And so that might be the reason why you see medical conditions and psychiatric conditions run together. Oftentimes, like in the literature, you'll see kind of like it's called something being bidirectional, like depression is bidirectional with diabetes and vice versa. So there may be very well like a common pathway. But what else do you want to do? You would want to see what mood symptoms, if any, there have been since discontinuation of whatever regimen they were on. So that's kind of my tips. I think there's
That's 3 minutes.
I'm Matt Jaffe, later faculty here. We've been talking about, a lot of treatments and diagnostic approaches that have been around for a long time. And I'm just wondering if you have anything that you're particularly excited about that people have been talking about for the future that might actually enhance our ability to diagnose and care for patients with bipolar disorder.
oh wow. In the future, there's nothing, I think for bipolar disorder, I'm not as certain. There might be some role for things to reduce oxidative stress. I would say for the unipolar depressions, I think that the next, sort of, it's already happening now, but I think, ketamine therapy is starting to gain some traction. I would say probably like instead of looking to the future, maybe looking back. I think if we're able to use lithium with more comfort, that's actually, that would be an improvement. It's shown to be very effective and largely, relatively safer depending on the dosing.
Amanda, do you want to?
Yeah, in the last like 30 seconds, I don't know if this is a TikTok trend, but I've heard a couple of my patients ask me if some of the disorders are actually autoimmune. And you mentioned kind of genetic background, but is this another area of exploration? And if so, how would that change the way we treat them? Sorry, that's longer than 30 seconds.
Yeah, that's hard to say. I mean, autoimmune encephalitis is on the differential, depending on the history. As for sort of a broader autoimmune cause, it'd be hard for me to comment on. I think I just maybe need a little more information to work with. Yeah, sorry.
Well, thank you, everyone. Thank you so much, Sean, for presenting, and thanks for everyone's patience with the technology. Feel free to give feedback on this talk, and then we will look forward to our talk in February by Dr. Farah.
All right, thank you, everyone. Take care. Have a great day.